All right, let's talk Dupuytren's contracture. What Dupuytren's is a condition of the skin, believe it or not, even though it affects your hands. Our skins have little cords in them to help support, almost like rebar that you have in cement, that helps support the structure of the skin. And those cords that run in this direction of the hand can have some genetic differences to where the cords over time can get thicker, produce these nodules or swellings, and eventually the cords can actually have some muscle filaments in it that cause the cords over time to contract. When that happens, these cords in our skin will actually, that run to the fingers, will contract to where the skin gets stiff, and you actually have a portion of the skin that's a visible and palpable cord that will not allow you to move the joints anymore because the skin is so tight in those cords. And we call that Dupuytren's contracture. Dupuytren's contracture is just a skin disorder. It doesn't affect the tendons underneath or any of the other functions. It's just of the skin. And this is something that you get in the hands, you get in the feet, and you can also get in some other sensitive areas in the body for men. On this part right here, what we end up doing is there's two ways to treat Dupuytren's contracture. The first one obviously is non-operatively, which we talk about. The first is bracing, where we can brace it and kind of help at night prevent that contracture from happening. But most patients don't usually like to have a brace on their hand all the time, especially when they're sleeping. It's not as functional for what they want to do. The second thing we can do is once we get the contracture to where it's affected about 30% of this joint or this joint to where 30 degrees of that bend we can't get back anymore, meaning it's stuck, or if it's stuck in that position, you can't get it straight again, then usually that means the cord is bad enough that we could do what's called Xiaflex injection. Now this injection is where we're injecting these little Pac-Men called enzymes that help to break down the collagen, which is what's in the center portion of that cord. When we inject that collagen, we then give it about 48 to 72 hours for those little Pac-Men to start chewing up that collagen. Then after 48 or 72 hours, we have you come right back, and then we pop the cord with a maneuver where we extend the finger and break the cord. Now, I know that doesn't sound like fun, but the benefit there is you have immediate relief of that contracture and you're not having this big skin incision. And so a lot of times Xiaflex has really become a huge movement in hand orthopedics so that we can avoid those big incisions. Otherwise, potentially your incision is a zigzag incision directly over that cord where you will expose the cord, cut it out, and then close that skin back. The benefit to that is you cut the entire cord and the nodules out. The downside to it is you're creating a new scar and become a new contracture. So a lot of us have gone to this Xiaflex injection, which seems to be very, very effective. The whole point of this being we're getting rid of that skin tether that's preventing us from bending our hands, and then we're allowing you to get back to that full motion. Sometimes what can occur is because the skin is tethered too much, you could end up having a contracture of the joint down deep where the skin tether and the contracture makes it so that joint doesn't extend. Sometimes we see that after a Xiaflex injection, when we release the cord, they still have that contracture. Sometimes that requires surgery. A lot of times it just requires some hand therapy. So the whole point of getting and treating Dupuytren's is to release or reduce the amount that cord in the skin can affect our function in our hand, and then be able to try to get your motion back with activity.